My name is Shaji Kumar. I'm a professor of medicine at the Division of Haematology at Mayo Clinic in Rochester, Minnesota. What I would like to do today is to talk about the important aspects of making a diagnosis in a patient with active multiple myeloma. As we all know, monoclonal gammopathies represent a huge spectrum of disorders ranging from monoclonal gammopathy of undetermined significance, which is the most common diagnosis in an individual with a monoclonal protein, to active myeloma or light chain amyloidosis or a variety of other conditions which are less common that requires treatment. The diagnostic criteria for multiple myeloma and related disorders were updated back in 2014, where one of the most important change was the recategorization of patients with high-risk multiple myeloma, high-risk smoldering multiple myeloma to active myeloma. Now, the spectrum of disorders, starting from monoclonal gammopathy of undetermined significance to active myeloma, can sometimes have a transitional phase called smoldering multiple myeloma. The most important step in terms of making a diagnosis of active myeloma is the distinction between the precursor phases of monoclonal gammopathy of undetermined significance and smoldering myeloma and active myeloma that requires therapy. The critical components for diagnosis of any monoclonal gammopathy is demonstrating the presence of the monoclonal protein, and in majority of the patients demonstrating that there are monoclonal plasma cells. So the demonstration of monoclonal protein will typically involve serum protein electrophoresis or electrophoresis in a 24-hour urine collection. In about 15% of patients where there is no intact monoclonal protein, a serum-free light chain assay can help quantitate the monoclonal protein and also demonstrate the presence of monoclonal protein. Now, in a very, very small proportion of patients, maybe 1 to 2% of the patients, there may not be any monoclonal protein that is demonstrable in the urine or in the serum. The second aspect is demonstrating the presence of monoclonal plasma cells. The most common place to look for those would be the bone marrow, even though they can also be found in circulation in some of the patients using the sensitive flow cytometric methods, and in plasmacytomas in patients who may present only with a plasmacytoma. Now, the first important point in terms of making the diagnosis is distinguishing between patients with active myeloma needing therapy or patients with smoldering myeloma that are high risk for progression and everybody else. So there are two important aspects to it in over and above demonstrating the monoclonal protein and the plasma cells. Smoldering myeloma is characterized by presence of monoclonal protein that's more than 3 grams or plasma cells in the bone marrow that's more than 10%. Now, the distinction between smoldering myeloma and active myeloma is based on demonstrating the presence or absence of end-organ damage like the crab features or the myeloma defining events. So presence of anemia or renal dysfunction or hypercalcemia will be detected on the serum studies or the blood studies that are done as part of the routine workup. The next critical point is the demonstration of lytic lesions, and this can be sensitively done by advanced imaging like whole body load or CT scan. So if you do a whole body load or CT scan and if you demonstrate lytic disease, you automatically make the diagnosis of multiple myeloma. If the lytic lesions are absent and the patients do fit into the diagnostic criteria for smoldering myeloma, it would be important to do an advanced imaging study like an MRI scan of the spine to look for lesions or a PET CT to make the distinction between smoldering myeloma and active myeloma. Now, this is important because once you make the diagnosis of smoldering myeloma, you also need to make a distinction between high risk and standard risk using the more recently published IMWG consensus risk stratifications for smoldering myeloma. And using these characteristics, if they have a high risk smoldering myeloma, these patients could be considered for early intervention or for participation in clinical trials looking at prevention of disease progression. Now, obviously, there are other associated conditions that need to be diagnosed as well. One of the common conditions would be light chain amyloidosis. And these patients, again, the initial workup will provide some clues. If you see significant proteinuria in the 24-hour urine, that should raise suspicion for amyloidosis. If the patients have symptoms consistent with peripheral neuropathy, or patients with cardiac symptoms should also be considered, or presence of light chain amyloidosis should be ruled out. And that includes, in addition to demonstrating the monoclonal protein or the light chain, the presence of amyloid in a tissue. And that can be achieved in over 85% of the patients by doing a fat aspirate and a bone marrow biopsy and staining this tissue for presence of amyloid with Congo red staining. And then if they are found, making sure that this is light chain derived by using mass spectrometry based assays. In patients in whom the bone marrow and the fat pad would be non-informative, you can always do an organ-directed biopsy, which then can give you the confirmation of the diagnosis and also typing of the nature of amyloid protein that's deposited. Now, in other conditions, for example, like light chain deposition disease, it is important with renal involvement, it is important to do a kidney biopsy. So when we talk about the CRAB features, the presence of renal dysfunction is fairly common in monoclonal gammopathies, particularly in myeloma. In multiple myeloma, it's typically related to Cas nephropathy, and these typically is seen in the context of somebody with high light chains, typically over 100 milligrams per deciliter or 1,000 milligrams per liter. In patients who present with renal insufficiency and a monoclonal gammopathy who does not have significantly elevated light chain, causes other than Cas nephropathy is likely to be involved, and a kidney biopsy might be important to make that distinction. And these patients often have renal lesions that's consistent with what we call monoclonal gammopathy of renal significance. Now, there are other diagnostic groups that also are less common. There can be monoclonal gammopathies that present with neurological problems, with skin problems, and also endocrine issues. Along those lines, it's important to talk about POEM syndrome, which is again a relatively uncommon condition, but can present with a single sclerotic bone lesion and a variety of skin and endocrine symptoms or laboratory findings. One additional group of patients that we often see are those patients with solitary plasmacytomas. The newly diagnosed or the newly revised criteria groups patients with plasmacytoma into two: plasmacytomas with no bone marrow involvement and those with minimal marrow involvement. So it's important to do advanced imaging studies such as PET scan to make sure, one, the lesion is isolated so that we can call it a solitary plasmacytoma, and also in terms of making sure there are no lytic disease, which would automatically place these patients into active myeloma diagnostic group. So there are certainly some nuances to making the diagnosis of these monoclonal gammopathies. Obviously, the first step is ensuring that there is a monoclonal process in place, and the second step is doing additional investigations in order to put them into the correct diagnostic group. Is it myeloma? Is it amyloidosis? Is it light chain deposition disease? Is it a plasmacytoma or a POEM syndrome, and so forth? And when none of these fit in, then obviously you have to think about the more rare conditions.